Hi, everybody, and welcome to the Lafora Talk Show. This is Season 3, Episode 7. I cannot believe the Lafora Talk Show has been going for 3 years. We are excited to join you today. I am your host, Tanya Friedman, Chief Executive Officer of Connetics USA. We are the #1 company for direct hire to the United States. Today, we have a very interesting topic, and I'm joined by my panel. We have with us Shannon. Hi, Shannon.
Hi, Tanya. Hi, everyone. It's
Hi,
nice to be
Shannon.
here
Welcome. We are also joined by Holly from Connetics. Hi, Holly. Welcome.
Good morning. Or good evening. Hello.
Wherever you are in the world. And last but not least, we are also joined by Mark from AMN. Welcome, Mark.
Hello, everyone. Thank you.
Welcome. So our topic today is ICU. We had on the Lafora Talk Show, I think it was 1 or 2 shows ago, we did a show on the clinical differences about working overseas, whether you're in the Philippines or in the Gulf states or UK, Australia, New Zealand, wherever you are, and the differences overseas as opposed to working in the United States. We then did a poll in Lafora, and in the poll, we asked which skill set are you most interested to find out more about, what are the differences, and ICU came out with the top number of votes. So today is all about ICU. We're going to be talking about what the differences are working as an ICU nurse in the Philippines as well as other places in the world, as opposed to working in the United States. We're going to be talking about orientation, what is important in terms of orientation when you come and live in the United States. We're going to be talking about the day-to-day. How is the day-to-day on the job different overseas as opposed to the US? We're going to be talking about technology. We're going to be talking about culture, cultural differences in the workplace, lots of advice, lots of pointers and tips. So please sit in. Please put your names into the chat, where you're watching from. We like to see all over the world. We have Mike, from the Philippines, Hemant from Nepal, James from Saudi, Sabana, seems an interesting topic. Thank you, Shabana. We have James, who's actually texting a number of his friends. So the Lafora Talk Show, everybody, is about nurses helping nurses and paying it forward. So if you are not an ICU nurse, please tag your friends and make sure that they are watching today. And if you are not an ICU nurse at all, please enjoy the show, because you're going to learn a lot about living and working in the United States. Okay, so we're going to get started. And before we get started, just a shout out to the Lafora Talk Show, the Lafora admin team, to Paul, to Kay, to Anna, to Louise, to Miss Jean, all of the Lafora admin who do such a fabulous job. Nurse One, James, in the Lafora admin, nurses helping nurses. Okay, so we're going to get started with introductions. Shannon, let's start with you. Do you want to tell us a little bit about yourself?
Hi, I'm Shannon, and I've been a nurse for about turning 10 years now. So I graduated on 2012 in Xavier University, Ateneo de Cagayan. It's in Cagayan de Oro, Misamis Oriental. Hi, everyone, to everybody's watching. And I took the nursing boards on December 2012. I got my license on around February 2013, because that's when they published the board passers at that time. And I started the job right away at a local hospital in my province. So I've been there pretty much around 2 to 3 years. And then I had the opportunity to go to Manila to have a dialysis training, because that was initially the track I was going for. And I did everything, the training. I got my certification in as a renal nurse. And then after that, I figured out I didn't want to go back to the province, because I was already in there. And if I wanted to go abroad, the vicinity to all the agencies and hiring companies are within reach. So I applied a job in there, and I got hired in a tertiary hospital. It's a Joint Commission accredited hospital. and I worked there for, let's say, about a year, more than a year. And then I moved to the UK in London on 2016, and I've been working there for about 6 years rather, and just moved here in the US in May, and here I am.
Okay, what an interesting story, Shannon. And I know so many of our viewers will relate to your story because it's, what you experience is what many people have experienced. The ultimate destination is the US, but sometimes it kind of takes a little bit of a windy route to get to that. You still have a little bit of the British accent.
Yeah.
So we're really excited to hear Shannon's story and find out more about the differences of not just working in the Philippines, but working in the UK and how that might different to the United States. Holly, do you want to go ahead and introduce yourself?
Sure. My name is Holly Musselwhite. I'm the clinical educator for Connetics, and I have been with them since late last year. And I've also been a nurse for about 20 plus years. Worked in a hospital setting, worked in post-acute and nursing home long-term care settings. And then my career has spanned, kind of back and forth between everything, but I've been doing international clinical nursing education and training for over 8 years now. So I always am fascinated by what I learned from nurses who have practiced overseas. And even throughout the US, there's practice variations, but certainly it's never dull when I'm learning from the nurses that we work with, the different things that they do and how they do it.
Thank you, Holly. So a great wealth of experience, and definitely we're really interested to hear your viewpoint. Mark, do you want to go ahead and introduce yourself?
Sure. So my name is Mark Jones. I am a clinical manager with AMN International. Some of you around the world may know us as O'Grady Payton International. Still the same company here, just a slightly different variation of the name. Been working in healthcare over 10 years. Majority of my time was spent as an ICU nurse, particularly in CV ICU. I've also spent a little time emergency department, bounced around a few different areas. And from what you'll find out when you come here to the US, I floated to many different units as well. But for the past 3.5 years, have been in my current role as clinical manager here, helping nurses in their transition to the US and what it is like to work here, give tons of tips, tricks, advice. We have a great support team, and I'm happy to join.
Okay, well, thank you, Mark. So between Mark and Holly, we certainly have a wealth of experience. And of course, Connetics USA was acquired by AMN. On Shannon, you said the 13th, you got your results, but it was acquired on May the 13th, so lucky 13. And so we are really honored to be part of the AMN family, partnered with O'Grady Payton, and really a wealth of many, many, many years of experience helping nurses to make the transition. Okay, so I see we have many nurses putting their names into the chat. So Shabana, James tagging his friends, Jason from Singapore, Legia from Qatar, Briggs from the UK. We've got Nixie from the UAE, Russ from the Philippines. Pearl is tagging her friends. Please, if you have questions about ICU specifically, and what the differences might be working overseas as opposed to working in the United States, put that into the chat, and I'd be happy to ask the panel any questions that you might have. And if you're not an ICU nurse, any questions that you might have just generally clinically, I'd be happy to put to the panel. Okay, so let's talk about ICU. Shannon, again, let's start with you. What was it like working in the ICU in the Philippines? And how was that different to how you worked in the UK? And how is that different to the US?
So in the Philippines, I think ICU is pretty much the same everywhere. You have to focus on your patient, around 1 to 2 patients at a time, and they are the most ill around the hospital. Like, this is the end point of their sickness. This is where they go to when they are really sick. So you have to have a very quick decision making. You have to do like you have to do multiple tasks at a time. And assessment, I think the very best trait as an ICU nurse when you're working is assessment, because when you see these warning signs, you need to know that, oh, this is there's an impending symptom that's coming. Then you have to report or collaborate with your colleagues about, this is what's happening to my patient. I think this patient needs something. And comparing to, I'd say, from the Philippines and the UK and the USA, when I was still in the Philippines, I was pretty tired. Pretty much I'm speaking for all Filipino nurses out there that are still in the Philippines. I was tired because the level of acuity and job workload that you do compared to the amount of salary you're earning is not at par with each other. And on top of that, sometimes you get to be called when there's not enough staff. When somebody calls in, you have to come in. Pretty much the technology, the equipment are also different. And what else was I gonna say? But yeah, pretty much everywhere you go, ICU in the Philippines, ICU in the UK, ICU in the USA, you need to be focused on your patients. There's not there's not. I mean, your patients are not 8 patients. There's only 1 or 2 of them, and you need to, at the whole 12 hours of your shift, you need to be focused on them. I think that's what I can say.
Okay, great, Shannon. So it sounds like the biggest thing that's the same is that you're dealing with the most critically ill patients. You've got to be collaborating with your colleagues. Assessment is really important, and being focused to take care of your patient is vital, because these are the sickest patients. So that sounds like it's the commonality. We're going to dig a little deeper into the differences in the rest of the show. But from your perspective, what is the biggest difference between ICU in the UK as opposed to the US?
There's a lot, actually, but for now, since we're going to cover more of it,
Yes.
ICU in the UK, when I say ICU, they call it ITU in there. And in the UK, it's 1-to-1. That's the ratio. Here in the US, it's 2 patients is to 1 nurse. However, in the UK, we don't have respiratory therapists. It's us that does everything. When patients are on dialysis, we do the dialysis as well. So most of these patients in the ICU have their own arterial lines. So we're the ones who take their arterial blood gases and run them, and we do wean them from the vent. So it's from our own judgment that we can wean them from the vent, because there's no RTs in there.
Okay. So we're going to dig a little more deeper into that in the rest of the show. So if you're only joining us now, we are speaking about ICU specifically and the differences of working in the ICU overseas, whether it's in the Philippines or the UK or Dubai or Singapore, wherever it is, as opposed to working in the United States. And we're going to talk about that in a lot more detail. So thank you for that, Shannon. So one thing that comes to mind, and let's move on to talking about orientation of coming to the United States, because obviously there's similarities, but there are a lot of differences. Mark, can you share with everybody, in your experience, why is orientation in coming to the United States so important?
Of course, the orientation when you arrive here to the U.S. is one of the biggest things that we help support on the clinical end in your transition. As Shannon mentioned, there's a bunch of different practice differences, but the orientation period really gives you that opportunity to build on your foundation of the different skills, different policies, different procedures. It's very often that you could be doing the same types of skills or same types of nursing interventions. However, maybe here in the US, we do them a little bit differently, or maybe there's a policy that says you have to take an additional step. So that orientation period is crucial for learning those different things. And oftentimes, maybe you have 10, 15, 20 years of experience wherever you are coming from in the world, and you feel like an expert in your setting. All of a sudden, when you get here to the US, not only is work new, but everything outside of work is new as well. You can kind of feel like a beginner again. And that orientation period really gives you the opportunity to build on those skills that you already have.
Okay, thank you, Mark. So that gives us an idea of what to expect on the orientation side. Holly, for many international nurses, it really is so unknown of what to expect in that orientation. And that's where I love the Lafora Talk Show and the Lafora admin who give us the opportunity to share with everybody the knowledge, because knowledge is power, right, of how what to expect. Can you give us an overview of what an ICU nurse can or should expect in terms of orientation when they come to the United States?
Mm-hmm. Sure. So most acute care settings have developed very formal programs for the ICU setting for orientation. They do that both for new grad nurses, there's a track for them, and there's also a track for new hire nurses with experience. Often hospitals choose to do a hybrid model of some of the new nurse information that might be given and the experienced nurse orientation process. Most hospitals will start with a general orientation that is some large overview topics of standards and principles for the facility. And then they will move within a few days into classroom information related to ICU topics. And that specialty area has so much safety risk to it that it's usually something that's very well thought out. And for the next several weeks, the nurse may go through training on the floor with a preceptor. Some hospitals have training labs where they'll take you in and practice certain skills, either as a general way to orient, or even if you need specific help in a certain area or skill that you're not comfortable with, they'll give you that opportunity. They're looking as well for the nurse to speak up if there's something that they feel they could do better on. So rather than looking at it as admitting you have a weakness, you can say, I'd really like to do a better job. And that's the way that the orientation can also become more tailored for the individual. But for several weeks, you'll have initially some classroom time and then time with a preceptor where you're on the floor at the bedside doing training. And I would say kind of the minimum I've seen with that is about 6 weeks. But many times it's going on beyond that to about 12 weeks or more. And most hospitals will tell you that they try to individualize it if someone is struggling or maybe needs help in a certain area.
Okay, so Mark has told us why orientation and training is so important, and Holly's given us an idea of what to expect in terms of how much classroom, how much on-the-job orientation and training. Shannon, what was the reality? What was your experience? Can you share with us your experience in terms of orientating when you were in the Philippines, in the UK, and how that was different in the US?
All right. So in the Philippines, I've worked with 2 hospitals during my entire career in there. The first hospital I've been with, the orientation wasn't that much of a focus. Pretty much, you come into the job. There's a day that you're introduced to the staff, to the team, and then the next day you're already doing clinical orientation. So when I worked in another hospital in the city, their orientation was pretty good. I mean, we've had 3 weeks of full trainings, all the trainings that you need, like refreshing your IV knowledge, ECGs, some BLS, and in the UK, it's also the same. I mean, there's a few weeks of orientation that you have to go to. So these orientation usually consists of what the hospital system is, what the hierarchy of the team members, who are these people, fire safety. I think that's pretty much almost everywhere. What's the process um, on like infection control? It's also part of the orientation, and some basic nursing skills. It's part of the orientation as well. And here in the US, I've had a week of like corporate orientation. So we were in the classroom. We were we were told about the vision, mission of the hospital, the team members, nursing skills, and the next week we had the whole week to do modules on the computer. And there's a lot of modules to do, by the way. And after that week of modules, that's when we did the clinical orientation with the preceptors. So we follow whatever the preceptor schedule is. And as Holly was saying, that it is based on like a clinical track and how many experience you've had. But as a nurse with pretty much almost 10 years of experience, I pretty much felt like I was still beginning again. Like I was a beginner, and I've been telling my director that um, I think the track that I was initially assigned with is around like 80 hours, and I told her, and she was very much understanding that I think it's better if I do this track because I am moving not just from one hospital to another. I'm moving from one continent to another, and things are not the same. So I have to go back there and take my time to just adjust with the workplace setting. So I'll be confident enough once I hit the road and start the duty on my own.
Okay, thank you, Shannon. And you mentioned there that you spoke to your director. So we're going to be speaking a little bit about that and how to manage up when you come to the United States and be assertive. So thank you for mentioning that. But I wanted to ask you, what did it feel like to feel like a newbie when you came to the United States? Because, you're an experienced nurse. What does that feel like?
Well, for one, it just felt like I was in a different place. I think, well, obviously I was in a different place in a different country, and I'm now in Tennessee, so sometimes I don't understand what other people are saying. It's hard to comprehend the southern accent, I'm telling you. And then I even asked my preceptor, she's a local, and I told her, "Do you guys understand each other?" And she told me, "Sometimes we don't even understand each other." So I was like, "Okay, so it's not just me then coming here as an overseas nurse and trying to understand what other people are saying." But yeah, everyone here is very lovely, and they know that you are starting. And myself, as for me, I try to ask several people, not just my preceptor, about stuff, because I think as a new starter, you need to be proactive for yourself. If there are some things that you need to learn that you don't know and that you're interested and you think that's a vital part for you to start your work and be on your own, you need to ask. You definitely need to ask, and ask several people. You get to learn from different nurses that you work with.
Yeah. Thank you, Shannon. I love that you say that, because for many, especially Filipino nurses, it's part of the culture to be taught to be shy, to be humble, not to ask. So we're going to talk about that later in the show, of just how to be assertive. But Mark, what we find with many facilities in the United States right now, many facilities don't have much experience in orientating international nurses. There's some that do and some that don't, because the shortage is getting worse and worse in the more recent years with the pandemic. So if a nurse lands at a facility where maybe the orientation isn't as good as what Shannon has experienced, what should a nurse be doing?
Yeah, I think that's a great question. And what I would say to that is you have to be a great advocate for yourself. You're coming here, as Shannon said, you're brand new. Maybe there's some cultural terms that you don't understand. Maybe you think that your orientation's a bit shorter than what it should be. So you really have to open up your communication. You have to be proactive in reaching out to your manager, your preceptor, your educator. And the great thing about coming to the U.S. with an agency like Connetics or, AMN International Grady Payton is you have a clinical support team here as well that you can ask questions to. So you have to really utilize all of your resources that you have. You have to take on that responsibility a little bit yourself. As you mentioned, culturally, our Filipino nurses oftentimes are a little bit more shy. They don't necessarily want to speak up. They're afraid that if they say something, they might get in trouble. 100% not the case when working here in the U.S. And I can tell you that from personal experience. I think I've worked in 14 or 15 different hospitals as a contract nurse here in the U.S. The biggest thing I have to say is you have to communicate, you have to advocate for yourself in those tougher work environments.
Okay, thank you, Mark. We're going to talk about that a lot. Advocate for yourself. Holly, if a nurse comes to the United States and is preparing for their orientation, is there anything that a nurse could do before they arrive here to get, quicker up to speed?
Absolutely. So if we talk about Connetics or AMN International, both of our companies actually offer some training modules, or what we call transitional modules, prior to the nurse coming in. That's to kind of also not only maybe refresh information that you already knew and solidify it a little bit more, but also to give you the opportunity to start to see potential differences. Sometimes Mark mentioned earlier, procedures, things that may seem very normal to people who've practiced in the United States, may seem very abnormal to someone who hasn't practiced here. And that includes sometimes to more westernized nations or locations that had a lot of the technology that Shannon mentioned earlier. So looking at what equipment and key procedures, and the sort of the step-by-step process and best practices. And I think it's important to go back to what Shannon mentioned earlier about knowing your patient. So when they're critically ill, if your assessment skills of listening to lung sounds, listening to heart sounds, assessing skin, assessing circulation, and understanding EKGs and how to read the basic rhythms at minimum, we want those things to be familiar to you. So while you may have practiced in an ICU setting overseas, there may be significant differences in technology that can be explored prior to arrival. Your assessment skills can be practiced. Even just listening to family members' lung sounds. Your stethoscope is your uniform or part of your uniform. So doing things like that can help you prepare. But the modules may seem a little bit frustrating when you're juggling so many other things while you prepare to come here. Just understand that when you get to work, if you're scared about the unknown, when you can go back to a solid reference that you've reviewed and say, okay, this had the principles that I needed to know, so I can fall back on those when I start to get anxious, as well as speaking to your preceptors and your educators, that completes the circle if you're having those resources and looking at things before you come, so that you can start to face some of those potential changes early instead of having it all descend all at once.
Okay, so I think, as Holly said, it's really important when you are deciding to come to the United States to do your research, do your homework. This is where Lafora is so valuable as a resource to many nurses, to be able to share their experiences and learn from each other, just like Shannon is sharing with you today. And just let me say kudos to Shannon to coming on the show and sharing your experience, because it is a bit nerve-wracking to speak to thousands of nurses all over the world. But you really are paying it forward, Shannon, and helping others. And we know that so many nurses are willing to do that. And, Mark and Harley spoke about the clinical programs, the transitional modules that, Grady and Connetics do. But there are many reputable companies that offer clinical training before you arrive and modules before you arrive. So do your research about that so that you can help prepare yourself. And as Mark said, be an advocate for yourself. So Aliyah is watching from Saudi, Kusua, Sheila from India, James is tagging his friends, or Jama's tagging his friends, Jovan from Philippines, Nina's watching, Kusua is in the UK, Denise has a question about the Joseph Silney, and the answer is yes, you can use Joseph Silney. Gulf from Pakistan. Giselle is tagging friends, Manish from India. So people from all over the world are watching today. Um, just before we move on to kind of the day-to-day job, Shannon, can you tell our viewers, when you think back to you either leaving the Philippines to go to the UK or leaving the UK to come to the US, from a clinical perspective, what do you wish someone had told you before you started orientation in either of those countries?
Um, I'm trying to think of what the best answer is. Um, I would say I wish people told me that no, let me just answer it differently. I think it's pretty much on the job, on the site. The orientation that I have experienced from the UK and the US, I think it's perfect. I wouldn't think of anything that I wish people told me about this or that. I think they pretty much covered everything while I was during the orientation. And as for me, I'm a very vocal person. I always express my thoughts, and I always tell them when I'm not sure. So I always I always write down my questions sometimes in like a piece of paper or a notebook, and then I ask them to my preceptor or to the director, and I get my answers pretty much um, correctly and swiftly. So I wouldn't think that there was something that I was missing during those times, because they pretty much covered everything. If that
Okay.
makes
So Shannon was fortunate, and we hope that each and every you, when you come to the United States, or if you're already here and are going through an orientation, we hope that you will be like Shannon and have a good experience. But if you don't, as Mark said, you've got to be your own advocate. I think that to me is one of the main messages that is coming through. Let's move on to talking about on the job. What is it like when you are day to day working in the ICU, and what is that day to day like? So, Shannon, can you maybe share with us the responsibilities of an ICU nurse in the United States and how that might be different to what you experienced before? So, just what is that day to day like?
All right, so let's start with the shifting. So while I was in the Philippines and in the UK, the shift is pretty much all over the place. When I was in the Philippines, it was an 8-hour shift. So you either get a day shift, an evening shift, or a night shift. While I was in the UK, it was 12-hour shift. But you get rotated from day shift to night shift. And well, I was here in the US. If you're a night shift, you're a night shift forever. If you're a day shift, you'll be day shift forever, which I think is really the best way to do it, because you don't get to mess up your body clocks. And if you know what the routine is during the day, then you're pretty much good to go. If you know what the routine is during the night, you're good for the rest of the week. And in here, um, one of the best thing that I've experienced compared to my other experiences is we get to do a self schedule. Although requests are subject for approval, but most of them get approved anyway, as a full time staff working in a hospital. So if you want to work just 3 days in a week, you want to work specific days, or if you want to, in those two pay periods, we call it paid periods. So that's a 2 week schedule, and the next 2 week schedule, because we get paid bi-weekly. If you want to compress all your shifts at the end of the pay period, and compress your next shifts at the start of the pay period, and you have a lot of days off. So I think that's one of the best things here. And I get to hear feedbacks. People are saying, nah, in the US, there's not much vacation, there's not much PTO and all that. but then you get to choose your own shift. So you pretty much have a lot of vacations in between. I think, yeah, it's one of the best things here, and I think it's pretty cool that I get to experience it.
Okay. I love that, Shannon. So you really have a lot of autonomy
Yes.
in how you dictate your time and how you can kind of give yourself that work-life balance. I was in the Philippines 2 weeks ago, and when you were talking about how exhausted you were when you were in the Philippines and the heavy caseload, I'm just thinking back of all the nurses that I was speaking to there, where they were like, oh my goodness, you just don't know where you are. Your body clock is all over the place because you don't have those straight days or straight nights. Mark, in your experience, do all hospitals have self-scheduling?
It's for the most part, yes. However, if you are coming in as a contract nurse, or if your desire to get here to the U.S. after you get your base experience is to move into something like travel nursing or contract nursing, there may be different facilities that don't necessarily allow self-scheduling for that particular class of nurse. Core staff, direct hire placement, more than likely, yes, you're going to have the ability to self-schedule. But keep in mind, depending on the hospital staffing needs, your request for self-scheduling may not always get granted. As Shannon mentioned, there may be times where the unit is very short-staffed, to where everyone wants off on a Thursday or a Friday. Unfortunately, someone's got to work those days. So the hospital may go by seniority. They may go in which order they received the request to have that shift off. So there's a lot of different ways that hospitals, or even sometimes units within a hospital, may approach that self-scheduling requirement.
Okay, thank you, Mark. And a follow-up question for you. I mean, you're an ICU nurse and you've also worked with international nurses for many years. What have you seen over the years as the biggest differences on a day-to-day basis working in the ICU that an international nurse might experience in the United States?
I would say the biggest thing overall is, you probably have to look at it as a big picture, is you need to be the driver of the care. And if you don't quite understand what I'm saying when I mention that, is you as the nurse, you are making the majority of the decisions for your patient. Not only are you a self-advocate, but you're a patient advocate. You're getting there in the day, you're starting with your report, you're doing your assessments, you're giving your meds, you're making sure orders get carried out on a timely basis. But as we all know, in the ICU, patients' conditions can shift rapidly. It is up to you to be identifying these changes, to go to the physicians or the residents, medical students, and say, hey, here's what's going on. I think we need this medication or this intervention ordered, rather than waiting for the physician to come to you and saying, okay, this is what's going on. Let's do X, Y, and Z. So you really have to be the driver of the care. You have to notice those changes, those rhythm changes. If you see a patient go from normal sinus rhythm to SVT, you have to immediately speak up and say something and act on that particular intervention. And I know we'll get into some assertiveness here in a little bit, but you really have to be the one who drives the care. You do have a lot of autonomy, as Tanya mentioned, in your scheduling, but you also are very autonomous in your nursing care as well. You need to be the one to kind of identify these different things.
Okay. Thank you, Mark. And being the driver of the care is definitely a theme that's coming out of the show, which I think is important for everybody to hear. I'm just looking in the chat. There are a few people that are talking about, I'm a night owl. I would like to work day shift. So I think, and I'm a nocturnal nurse. I love that people are commenting there and sharing their preferences. And the great thing about the US is that hopefully, as Mark said, you will be able to get your it might not always be perfect, but you will be able to get your preference. Holly, we have a question from Juma who's asking, department indicator wise, the scope of services must be. I think, if you can talk maybe a little bit about the scope of responsibilities, and also how the pandemic has factored into that.
So the scope of responsibility for the nurse can be pretty consistent when we talk about the ICU setting, because they're so critically ill. We know that the ratios are usually going to be 1 nurse to 2 patients, and also that there are ancillary team members like respiratory therapists who are going to be monitoring that patient. Many times they're looking at the ABGs arterial blood gases, and they are deciding on, maybe this is the best setting that this patient needs on their ventilator to be able to either maintain the status that they're in or to begin weaning off of it. But the responsibilities are also sometimes guided by what other departments the hospital has decided to keep in their team. So sometimes we have specialty nurses who will come in to do services like hemodialysis or continuous renal therapy, CCRT. And we have people who will come to do lab work or blood work or pick up or bring certain things to the nurses. And we also may see that nursing assistants are present, or what we call nurse aides or nurse techs may be present. During the pandemic, we saw a lot of hospitals have to get creative with making sure they could meet patient needs. So not only did we see certain zones of the hospital become dedicated to COVID patient populations, we also saw nurses that got cross-trained to be able to work with those patients. We had nurses who might have learned how to work with ventilators who had never really done much of that. We had changes in who might be allowed to come on the unit, which meant that if that ancillary department wasn't able to come in and deal with certain things, the nurses might end up being responsible. That could include some things like restocking. So carts might have been left outside of units for them to be brought in and things to be restocked. There were procedures that were put in place that totally changed the flow of how the person moved in and out of the unit and in and out of rooms. We saw equipment that they wanted to leave outside of rooms so that it could be adjusted for different drip rates and things like that. And so the changes that took place because of COVID and that pandemic showed, I think, that a healthcare system who's burdened can also learn very quickly how to try and make changes. So we gripe sometimes in the healthcare world that, surely there's a better way to do this, or why does it take so long to make changes? But when push comes to shove, we've also seen that we can make those changes. It does put a lot of pressure on the nurses and the physicians. We also saw more telehealth. So physicians might look at the patient from telehealth far away.
So lots of changes that came out of the pandemic, and certainly hospitals had to adapt very quickly with that. And that's where also I think a lot of nurses, and not just in the ICU, have been suffering from burnout, and that's a topic we're going to be talking about in a follow-up show. So moving on now to talk about technology, and I know we have people all over the world here. Paula's watching from Brazil, Jacqueline from Kenya, Joma from Kenya, Dodong from the UAE, Okweme from the UAE, Ya from Ghana, lots of people from all over the world. One of the biggest differences, Denzia from Tanzania, one of the biggest differences is the technology when you come to the United States. Shannon, can you speak a little bit about your experience about technology and if that was different or not for you?
I would say if so coming from the Philippines, there were two hospitals that I've worked with, and in the UK, and coming here, there's when you go into ICU, there's always should be an infusion pump or a syringe pump. You can't just hang a dobutamine or dopamine free flowing telling you to do 10 drops per minute. So there's infusion pumps. However, there are different brands of infusion pumps. So you just have to get acquainted with them, and you will have a lot of time to play around with it anyway. Also, I think the most difference would be here in the US, everything is electronic. So when you come to work, you don't even need to bring a pen with you. I mean, you just have to go to whatever medical record system your hospital have. Like for us, we have Cerner. So you just bring your badge, log in and tick whatever assessments are in there. Just basically a tick box. It's not like you do like a narrative charting. We don't do that here unless there's an event, a big event that happened to your patient, and you would like to narrate what happened, and you'd like to corroborate them all, so people can see what your notes are. So I think that's the only time that I would rate, but most of the time it's just a tick box. Also, the beds will there's a weighing scale for the beds. So sometimes, ICU patients, most of them cannot stand or cannot sit. So if there's a certain medication that needs a medication that needs a way to calculate the dose, or antibiotics for such, then you can just weigh your patient on the bed. Um, the ventilators here are, speaking on my own experience, they have they have updated to what the latest ventilators are, which I think it's fantastic, because there's more settings that are involved with it. Um, One thing that I've been so amazed with when I arrived here is the Pure Wick. So this is for you all people who don't know what a Pure Wick is. Um, I think in here, most facilities, they want to avoid UTIs. So as you can't just put a catheter for the reason that you want to be free of not using a bedpan for your patient, because they have a catheter, they can just pee and it's going to be easy for you. However, in here they want to avoid indwelling catheters as much, so we have a Pure Wick. So it's basically a thing that we put in a female's private part, and they just pee in it, and it gets suctioned to a suction canister, which I think is very amazing at the same time.
I love it. So many interesting new things to learn about and to see, and so innovative. Mark, you're an ICU nurse. What are some of the latest technologies that a nurse might expect to see, depending on the hospital, in the ICU?
Yep, I would say PureWorks definitely one. I think that just came around even in my last year of working the bedside, so it wasn't even around for my whole career. But as mentioned, you may see, depending on which part of the world you're coming from, if you're working in maybe a smaller community hospital in the Philippines, as opposed to a larger teaching hospital in the UK, your experience with the technology and the equipment is probably going to be vastly different. You may see some of the technology pieces, but as Shannon mentioned, it's probably going to be a little bit newer. There's going to be some different buttons on it. You're depending on which specialty of ICU you're working in. So, for example, CVICU, you may have a different type of CRRT machine. You may have an LVAD or an Impella balloon pump that's different, or maybe you were working at a hospital that was not really a chest pain center. They did not have a cath lab, so you medically managed any sort of cardiac conditions. So, going to a newer institution here in the U.S., you're probably going to have that Impella or balloon pump or something like that available to you. The biggest thing on some of these things that I would say, though, is, I wouldn't say they're necessarily hard to learn, but it's going to take some time and repetition. That's one of the biggest things I tell the nurses that I work with is time and repetition will get you better with that technology, whether it's computerized charting, whether it's an IV pump, whether it's a tube feeding pump. Many of you may be accustomed to running your tube feedings or enteral feedings by gravity, and it may be a bolus feed, but here in the ICU, you're going to run it over a feeding pump, and you're maybe going to run it at 60 cc's an hour for a continuous feed 24 hours at a time. So lots of different pieces of technology. It can be overwhelming. Just know it takes time and repetition. Biggest thing I say.
Time and repetition. I like that. I think that's a great way to think about it, because for many nurses, it's very frustrating. I mean, it's exciting, as Shannon said, you look at things and you're like amazed. Oh my gosh, look at this. But at the same time, it can be frustrating, especially if you come from a country where there is no electronic medical records, and you maybe it's not as computer driven. Holly, what can an international nurse do if they come from a country where there's no electronic medical charting? and maybe they haven't seen some of the things that Shannon and Mark have spoken about. Is there anything that can be done before they arrive here?
There is. So many systems operate on either laptops or computers that have a desktop computer. So being familiar with just the device itself, and knowing how to click boxes and stuff. We see nurses who say, "Well, I can use Word on my computer." That's a step up from not being able to use Word. So getting familiar with basic computer functions, not using tablets, we see more often, but they're still not mainstream for the majority of the functions that you would be doing in the hospital. So we need a laptop with barcode scanning. The other thing that's really awesome is that all over the web, most vendors have provided videos that will show you, like if you look for Cerner or if you look for Epic, those are two main documentation systems, and you will see examples of what that looks like for nurses. So while each system can be customized, you would be able to get a glimpse of that before you come here. For some facilities, there may be a little bit of narrative noting, but as Shannon mentioned, most of the time it's clicking boxes. So be familiar with your mouse, with your trackpad on your laptop, and with navigating between screens and what some of the symbols on your computer may mean. So the enter function and the return function are on the same button. What would I do with that? It's very basic, so that when you get to the computer itself, you're not feeling timid or uncomfortable. You can demonstrate a decent degree of comfort, and then watch those videos on YouTube that introduce some of those systems. Even if it's put out by somebody that you're not going to work for, it will give you a rudimentary idea of what's in the EMR, as well as doing some of those modules that we talked about earlier.
Thank you, Holly. So at least that gives a lot of people comfort to know how to prepare, because that's, the Lafora Talk Show is all about knowledge is power and how to empower yourself. And before we move on to the final segment, which is the culture that one might experience in the ICU in the hospital, I'm going to just take this one question from Juma. Juma has a question. One, research or protection of nurse various stage in corporate. It should be route line now to safe nurse workplace trauma legal wise in worldwide every stages. I think, I'm not sure exactly what Juma's question is, but I think Juma might be asking about, like, from a legal perspective, if there's a mistake in the ICU, how are nurses protected? This is an important question. Mark, maybe you can answer that question for Juma. I think that's what Juma's asking.
Yep, and that's a growing topic here in the U.S. If you've seen the news, you've seen some of the nurses in the news after they have made a mistake. And the biggest thing I will tell you when it comes to if a mistake happens, because mistakes do happen in nursing, is immediately self-reporting, and your documentation is key. If you ever, if you find yourself having made an error, or maybe you received a medication from pharmacy and it's got the patient label on it and everything, and here in the US, you have to scan your medications, and you scan the medication, it scans fine, but then you look at the bag and notice, oh my goodness, there's a different label on this medication. It's the entirely wrong medication. You still have to do your 5 rights. Even though you have all this technology and all this equipment, you can't forget your fundamentals of nursing. You have to do your 5 rights of medication administration. You have to know the orders that you are carrying out. You have to understand how to complete the interventions that you're doing. And if you don't, you have to be able to speak up, grab your charge nurse, grab your mentor, grab your preceptor, educator, whoever you can, or just your colleague next door. Say, hey, I've never inserted a nasogastric tube before. Can you come help me out with this? And then the other situation and questions that we get is, as we've mentioned, maybe you're going to be at an understaffed hospital. Maybe it's pretty rare, but sometimes in the ICU, you can end up a 1-to-3 ratio with patients. Maybe your third one's more of a step down type patient, but there's no room on the step down floor. Now you're feeling a little bit more kind of uneasy and a little bit unsafe at times. So if you feel like you are truly in an unsafe situation in terms of your patient assignment, you need to, one, immediately escalate to your charge nurse. If you don't get a satisfactory answer from your charge nurse, you're escalating to the nurse manager. And I know what some of you are thinking, oh, I work night shift. How am I supposed to escalate to the manager? You send an email. always follow up your escalations with an email to that manager, to that charge nurse, whoever it might be. That way you are documenting the steps you have taken. Then that will in turn help protect you, help protect your license. So the key components: quickly identifying if an error was made, a mistake was made, filing those reports and taking the necessary steps. Don't forget your fundamentals, and then follow up your documentation to the nurse manager with an email.
Okay, very, very important advice, everybody, from Mark on how to practice safely in the United States and protect yourself and your patient. Moving on to the work culture, Shannon, this is the last segment we're going to talk about. How is the dynamic in the ICU different to the dynamic that you might experience in the United States? So how's it different in the Philippines as opposed to the United States? So like, what is the relationship like between nurses and their colleagues, or nurses and the physician in the Philippines as opposed to in the United States?
In the Philippines, I would say when doctors come in, you get very intimidated because as a nurse in the Philippines, I mean, I'm speaking on my own experience. I think that's what other people are also experiencing. You feel like you're not at level with the doctors. Like you're kind of below them, so you feel intimidated. If you need to ask something, you're afraid that you might get penalized for something, you might get reprimanded. That was what I have experienced before. And you need to do an S bar. You need to call them on a right on the right time. And like you don't just call them for some petty things.
Mm-hmm.
So you know what I mean. It's hard to to contact them at the same time. So if you want to call them, you need to really make sure that your patient is this and that, and I need your help. However, as for me as a night shift nurse, we can also call the doctors, but we have our nurse practitioners as well at night. And while I was in the day shift during preceptorship period, I think the relationship is pretty good. Like when the doctors pass by, they're greeted by nurses, and they talk about random things, not just clinical, like how's their vacation. It's a pretty good relationship. I would say it's like they're friends. It's friendship. It's way beyond being work colleagues. It's you get to ask how the kids are, how's their vacation, which I think is very good as in a hospital setting, being able to speak out to your doctor, ask them how things are. That's a very good relationship, and you're not intimidated. And I know because in this hospital that I've worked with, and also previously, well, in the Philippines before, because they're accredited. So the Joint Commission, DNV, there's several accreditations in the USA. And you know as a nurse that you are protected because doctors can't just reprimand you for what you've done. Otherwise, they'll be penalized. They'll get a notice for what they've done if you tell your director that this is what you've experienced. They're going to get penalized for it. So as much as possible, they want to have a very good relationship with the nurses, because at the end of the day, when they order something, they want their orders to be done quickly. And if you've had a good relationship with the staff, with the nurses will be pretty much very eager to do it as much as they can, as quick as they can, just to complete that order for that specific patient.
Thank you, Shannon. So it sounds like one of the biggest differences is that in the Philippines, there's a very much a hierarchy. There's the doctors, the physicians, and then the nurses are here, and it's not always easy to communicate. Whereas in the US, it's much more kind of informal in a way, in a lot of ICUs and a lot of hospitals, and you really have to be much more independent as an ICU nurse in the United States and more assertive. Holly, many international nurses, as we've said before, are taught to be shy, taught to be, it's part of the culture, it's taught to be not assertive. How can an international, first of all, what is assertiveness and how is that different from being aggressive? And how can a nurse be proactively more assertive?
So assertiveness is basically a willingness to speak up and vocalize your concerns and address them head on. Aggressiveness is seen as more confrontational and it has a more negative connotation because of that. So it's important that you consider the opportunity to be an advocate, both for yourself and for the patient, is also a duty. So if you don't speak up, that's actually seen as an unprofessional thing. If you were to make a mistake and be trying to address it, and it comes to be that you didn't speak up and you didn't make that known, most of the time that needs to be addressed right away, because we want to prevent future mistakes. So speaking up before mistakes happen because you weren't quite certain or you were uncomfortable is actually a safety mechanism. And assertiveness is not looked upon as a negative thing. It's looked upon as a very important skill to have. And I think you can practice it before you get here. So when you're speaking with team members, both on our team or with your colleagues, assertiveness would say, maybe there's something that you feel uncomfortable with. Can you speak to your colleague even and vocalize, I'm uncomfortable with this. Can you share more? Or can you teach me how you do that? And that's really what we're talking about, is speaking up and being willing to be a little bit vulnerable, but knowing that by doing so, you are advocating for ultimately yourself as well as the safety of the patient. And that is key to any role you're going to play in healthcare.
Okay, so assertiveness, not aggression, because there's a difference, is definitely encouraged in the United States. And that's something, as Holly said, that we need to practice. Mark, final advice for international nurses. You are an ICU nurse. You have seen hundreds of or thousands of nurses come through to the United States. What would you say is your final piece of advice, Mark, for nurses coming to the United States, ICU nurses?
I would say, especially when you're starting out, one of the biggest things is no one knows your clinical skills better than yourself. You know what you are good at, you know what you are not great at, and you know what you just haven't seen. So I think the key in kind of going off what Holly said is you have to speak up and you have to address situations before they would become an issue. So, if you're in your first couple of weeks of being a new nurse here in the US, as Shannon has mentioned, maybe you're an expert previously, feeling a little bit more new, more of a beginner here, you have to say, okay, I need some more help in these areas. I need help with my EMR. I need help with this particular intervention. But those other areas that you are confident in, go ahead and show that you are confident in those skills. If you know you are great at assessments, when you get to work, okay, let's go assessment. Tell that to your preceptor so they can see that little bit of assertiveness, that proactiveness from you of wanting to go ahead and get those things done so you can focus more time on those areas that you might need a little bit of improvement. And then secondly, probably 1A and 1B, communication. You have to be able to communicate well with your colleagues, with your agency, with people outside of work, because that is really how you build relationships here in the US, is through that open communication, that open dialogue. Doesn't always have to be talking about clinical, talking about work. As you mentioned, how was your vacation? How are the kids? Are they in school? Building those relationships through communication, because you'll find that you learn a lot that may help your clinical practice as well. There's going to be terms that you don't know moving here to the US, little slang terms, or as Shannon mentioned, those Southern accents. So the more you talk with people, the more that can in turn help your clinical performance, because now you're learning new things in terms of your communication.
Thank you, Mark. So great final words. At the end of the day, it's about communication. And that really is the key component. I want to thank Shannon Harley and Mark for today's show. It was so informative, so interesting to learn about the differences in the ICU from a clinical perspective, from a cultural perspective. What is the orientation? What can one expect? Please tag your friends and pay it forward by sharing the show with them. I want to finish off by thanking again the Lafora admin who do such an amazing job by helping nurses and providing a platform where nurses can help each other. Just a final note before you leave, some upcoming shows. So we have on the Connetics show, Onwards and Upwards, everything that a global healthcare worker needs to know. On the 19th of August, we have our regular question and answer, bringing in the legal immigration panel. On the 26th of August, we have the cost of living in the United States, how different states have a different cost of living and what to learn about that. September 2nd is navigating RN employment benefits in the United States. Very confusing for Americans, so just as confusing for international healthcare workers. On September 9th is how to buy a house, living the American dream. 16th is immigration Q&A. And then the Lafora talk show will be back on the 20th of September, where we're looking at clinical differences in the ED. So if you're an ED nurse or you know an ED nurse, please make sure to note that date. And on the 23rd, we are doing stateside, where we will be looking at different states in the United States and what it's like to live as a healthcare worker. And last but not least, the Connetics College. This is every Monday. You can go to the Connetics USA page, and there is free information for you to prepare you. Upcoming shows every week, every Monday. On this coming Monday, we have Niners, one of our Connetics partners, fabulous Niners. Irvin will be doing OET class on the spot writing on the 22nd of August. Thank you, everybody, for joining us. We look forward to the next Lafora talk show in a month. And thank you again to the panel for sharing your insights, your journey, and your wisdom. Bye-bye.
Bye.